show the
No,
management,
no,
surgical
I'll do it very
management,
quickly. We have little
dermolipoma?
time left.
Thank
I'll
you.
be talking about the management of ocular surface tumors as a group. So when you have a tumor, it could be a malignant tumor or a benign tumor, and since at least 40 to 50% of ocular surface tumors happen to be malignant, you have to combine your surgical skills with excellent oncological principles to optimize the outcome. Now, at the outset, let me enumerate what are the oncological principles that you actually need to take care of. One is to accurately determine the diagnosis and extent. If you diagnose a malignant lesion as a benign lesion clinically, obviously you'll be short of your excision. Not to use topical therapy when you're not sure of the diagnosis. If something looks like OSSN and you're not sure of it, then don't use topical therapy, and don't use topical therapy unless you have determined the depth of the lesion. If the lesion has already involved the sclera or corneal stroma, topical therapy will not work. Whenever you take care of the tumor by surgical excision, you have to take care of the edge and base clearance. Base clearance is more important than edge clearance because that's something subtle that you're leaving behind, which will result in local tumor recurrence, not just on the surface, but intraocular as well. Always give due weightage to histopathology and provide histopathology guided adjuvant therapy. Screen for regional lymph nodes, which is very important if you're looking at a patient with melanoma, and for patients with lymphoma, obviously systemic evaluation, and provide target therapy wherever required. So imaging is mandatory in ocular surface tumors, not just to diagnose a nevus from a melanoma, which I'm not going to elaborate upon, but it is more important to determine the depth of the lesion. For example, in this particular lesion, the diagnosis is obvious, but you're not very sure of the depth because these lesions tend to be hyperreflective and there is some amount of shadowing, but otherwise you can actually know the depth of the lesion, to what extent has it involved the sclera or cornea. Now, about topical therapy, we have chemotherapeutic agents as well as immunotherapeutic agents. Mitomycin and 5-fluorouracil are chemotherapeutic agents, whereas interferon is the immunotherapy. The dose is listed here. I'm not going to elaborate upon the dose, but we have a minimum response time for each of this. You have to try mitomycin for at least one cycle, 5-FU for one cycle, and interferon for 6 weeks before you declare that the patient is not responding to treatment. And the maximum duration of treatment is also there, beyond which if you continue, the patient will have limbal stem cell deficiency and corneal epithelial problems. When you talk of immunotherapy, interferon, you have immunotherapy, immunoreduction, and immunomodulation. Therapy is to cure, reduction is to reduce, modulation is to modulate the ocular surface so that new tumors don't crop up. Small tumors can be taken care of by a 6 to 3 months treatment with interferon. This was a small recurrent tumor, again resolved with interferon. Corneal OSSN is a standard indication for topical therapy. This is a patient where the biopsy was done here by a cornea specialist. That's the exact area where there's a residual corneal scar. Rest of the treatment was done with topical therapy. So if you have a corneal OSSN, if you try to excise it, you may leave behind a subtle corneal scar in the pupillary axis, thus precluding good vision. OSSN, unfortunate situation where patients with xeroderma can have OSSN at the graft-host junction, which is very delicate. This patient had a valuable third graft. 2 of his prior grafts had failed, and you cannot take risk by surgically excising these lesions. These are best treated with topical therapy. Tumors which occupy more than 6 or 7 clock hours of the limbus can cause limbal stem cell deficiency if you try to excise them, although you can, to a certain extent, take care of it by primary limbal stem cell transplantation, but still it's a good idea to use topical therapy. Diffuse flat tumors, tumors which are placoid, are best treated with topical therapy, whereas these tall boy lesions are best treated by surgical excision. So you have to take care of the configuration of the lesion as well. This was treated with topical interferon for several weeks and it resolved. Immunoreduction is a principle where a large surface tumor can be reduced to a small lesion. That's because what is left would be the invasive component of squamous cell carcinoma. What goes away is the dysplasia carcinoma in situ component. So when you're left with this, be sure that that's the invasive component or squamous cell carcinoma component of OSSN, which you must surgically excise. Immunomodulation is for patients with xeroderma pigmentosum or HIV patients who tend to recur or have new lesions. Now, diffuse OSSN can be taken care of by injection interferon. This is very good for eye salvage, where otherwise you would do orbital exentration. At least half of them you can prevent doing orbital exentration if you were to give injection interferon along with aggressive topical interferon. When diagnosis is in doubt, such as pegyroid sebaceous gland carcinoma, don't be aggressive with topical therapy. You have to establish the diagnosis first. When you're not sure of the depth, again, no topical therapy. When you're not sure of patient compliance, surgery is the best treatment. When you talk about surgery, there are three issues here: excision with edge and base clearance, alcohol-assisted keratoepithelectomy for the corneal epithelial component, and excision edge cryotherapy gives you an additional benefit of about 3 to 4 millimeter. Edge is very easy to determine. When you stain the tumor with rose bengal and take care of the subtle thickness of the conjunctiva beyond the clinically evident lesion, which you can only note by slit lamp evaluation, edge is crystal clear. But what about the base? You cannot determine base on slit lamp evaluation because you simply cannot see the base, and what is required is anterior segment imaging, either OCT or UBM, which will tell you that this patient has full thickness corneal stromal involvement already, so excision is not going to help. This patient will need either a penetrating keratoplasty or brachytherapy. It's a good idea. See how beautifully my mentor draws Carol Shields' diagram, which I have preserved over 25 years. This is how she maps out conjunctival melanoma so beautifully, all lesions marked, and this is what we take to operating theater. Right now we use digital photographs, but nothing short of hand-drawn pictures of this sort. Of course, excision is very simple, where you map out the lesion, go 3 to 4 millimeter beyond it, excise it, whatever instrument that you prefer. Monopolar RF, bipolar RF are very valuable in terms of controlling or having hemostasis at the time of surgery. But if you don't have access to it, scissors and blade would simply do. That's not a problem. But once you excise it, you have to use certain oncological principle. Always hold the edge of the conjunctiva with non-tooth forceps if possible. Don't hold the tumor ever. Reach the limbus from the conjunctival side. Cauterize the feeder blood vessels at the limbus. Apply absolute alcohol to the leading edge of the tumor. 3 to 4 millimeter of the epithelium should be de-epithelialized using absolute alcohol. Once that is done, the corneal epithelium is denatured and it also scrolls back beautifully towards the limbus. So you're reaching the limbus from the corneal side as well. So you reach the limbus from the conjunctival side already. Now you're reaching the limbus from the corneal side. You have to finally do lumpectomy because OSSN is a tumor of the limbal stem cells. So once you've reached the limbus from the corneal side, you start from one edge of the tumor, perhaps the superior or the inferior edge depending on your ergonomics, and you excise the tumor off the limbus. Then you do excision edge cryotherapy and repair the ocular surface with amniotic membrane. These patients tend to do well. But what about patients who are beyond surgery, patients who have scleral invasion? We were enucleating them, extended enucleation of course, or exentrating them. No longer so, we can take care of them by using plaque brachytherapy. Mainly because the scleral or the intraocular component can be easily treated with about 6,000 centigrade of ruthenium plaque. This is how nice results are. Sclera does not melt even with high dose of radiation. This is secondary plaque brachytherapy after excision, but if you have a tectonically unstable cornea which is already showing stromal melt or weak sclera, you cannot try to excise them without leaving a tectonic defect, which is impossible to repair. So you do primary plaque brachytherapy, which also works well. Melanoma, of course, plaque brachytherapy is useful as an adjuvant measure for the scleral component. Large extensive melanomas, this patient had about 270 degree of melanoma, multiple recurrences, small intraocular component. You can see the ciliary processes there. That's the intraocular component of melanoma that could be taken care of by plaque brachytherapy with good outcome. Plaque has about 90% success. This has recently been published. Patients with intraocular extension, young patients who want eye salvage, we have stereotactic radiation. This patient had choroidal involvement as well as exudative retinal detachment, completely settled following stereotactic radiation. That's MRI guided stereotactic radiation that we delivered. You can see nice results. Not all patients respond this beautifully, but this is one exceptional case where we wanted to do eye salvage because of the request of the patient. These patients need orbital exenteration. Adjuvant therapy is based on histopathology. Resection edge positivity only displays your carcinoma in situ. If you have already done cryotherapy, nothing to do, simply observe. If you haven't done cryotherapy, then you have to do topical adjuvant chemotherapy or immunotherapy. Resection edge positive with invasive squamous cell carcinoma, medico-legally you are bound to do re-excision. There is no escaping that. Resection base positivity, localized cryotherapy. Resection base positivity, diffuse plaque brachytherapy. Margins and base negative, but the patient is prone to recurrence, then you do immunomodulation. Lymphoid tumors, of course, incisional biopsy or complete excision is mandatory, followed by rest of the treatment. For lymphangioma, bleomycin or vaporization with resurfacing. Target therapy mainly for lymphomas. You can use localized target therapy such as perilesional rituximab, which works for conjunctival malt lymphoma specifically. For conjunctival melanoma, depending on the mutational spectrum, we have many drugs, pembrolizumab, nivolumab, etc. This patient has regional lymph node metastasis for which he got approval for nivolumab, and you can see the disappearance of the conjunctival lesions as well. So ocular surface tumors, if you do these, manage these with protocols, then you have less than 5% recurrence rate, less than 2% of regional lymph node metastasis. If you don't use protocol-based technique, then you have a much higher chance of local tumor recurrence and regional metastasis. So simple application of oncological principles can actually help improve the prognosis of these tumors, especially in terms of local tumor recurrence and also systemic metastasis. Thank you so much.